Hi, welcome everybody. Just as I can see people are joining. Great. It's always very exciting to see the numbers cranking up on the bottom of the screen. One of these days we will, I'm sure, be back seeing each other face to face in a room. But in the meantime, and actually particularly perhaps at the moment when numbers are still not great in terms of being free from COVID, at least we are able to join virtually, which is certainly better than not being able to join at all. These have been really interesting webinars so far. We're focusing on community palliative care, but there's such a lot of interplay between primary and secondary care that actually the journey of the patient is seamless as they move between the community and hospital. So depending on where you're working, where you're from, then you are very welcome. Please share your ideas and your thoughts. We do also have a section at the end, back usually to the 20 minutes or so, after the webinar's finished at 2. If you wanted to stay on, we don't record it, but it is an opportunity just to perhaps ask some practical questions about patients. However, we do say, please do the usual, we patient regard for patient confidentiality, so no names and no names of colleagues, but there is that opportunity for a slightly more in-depth discussion if there's anything that particularly you want to ask. We've got people monitoring the chat, so at various points during the webinar there may be opportunities for you to express your views, ask questions, so do use the chat. We've got the opportunity potentially as well at the end to unmute your microphone, so to ask a question in person, but we will be monitoring the chat, and so kind of to help get the ideas going, please don't be afraid to use it. So without more ado, the focus today is managing breathlessness, thinking particularly around issues for COPD and for heart failure. So I'm joined by two fantastic colleagues, Jo Hayes and Claire Atkinson from Cardiff, who are going to deliver the session today. Thank you so much. Jo, over to you.
Thanks, Fiona. Hi to everybody again, for those of you who've attended previous webinars. So my name's Jo Hayes. I'm a palliative care consultant based at the Marie Curie Hospice in Penarth, and I work with the community team covering the Vale of Glamorgan. And my colleague Claire Atkinson, who will introduce herself a little bit later, is palliative medicine consultant in the acute hospitals in Cardiff and Vale, UHW and Llandoch, and is part of the heart failure supportive care team. Thank you. So as previously, we're palliative care specialists in general, although Emily Johns is Macmillan GP facilitator and part of the group that have set up these webinars, who's obviously from general practice. But as always, we look after patients working in conjunction with our acute hospital colleagues, GPs, district nurses, the ambulance service, the out of hours service, pharmacy, staff in nursing homes, social care and hospice at home. So it'd be great if we could just see who we've got on the call, if that's okay. So Charlotte, do you mind just launching the first poll? Thank you. So if you could just put in your main role. So I'm going to talk because on the recording, people can't necessarily see the polls. So GPs or GP trainees, district nurses, palliative care team, other nursing, and a few other professions there. Okay. So we have got about half of our participants are GPs or GP trainees, and then we've got some district nurses, some other nurses, and we haven't specified somebody from social care and members of the palliative care team. So thank you. And Charlotte, if you're happy to just run the next poll, which is about the setting that people work in, if that's okay. So just wanted to ask what's your main setting of work, whether it's community, acute hospital, or elsewhere. Charlotte, have we got the second bit of poll? I'm not seeing it on my screen.
It is on my screen. So we've got 68% are mainly community, 10% mainly nursing home, 10% secondary care, 9% specialist palliative care, and 5% are a mixture.
Thank you. Thank you very much. Not sure why I can't see that. Okay, Great. Okay, so I hope to cover some of the approaches to breathlessness in palliative care patients. So patients with things like cancers, COPD, or degenerative disease, or just general frailty, really. And then Clea is going to talk more specifically about heart failure. So I'm going to ask you questions a little bit, and it would be great if we could have a bit of interaction. It's difficult on bigger Zoom calls, isn't it? But I will maybe ask people to put comments and questions or thoughts in the chat, and I'd be really grateful if you could try and put some stuff in so we can feel like we're communicating with each other. And you can ask your own questions in the chat as well if needed, and we'll try and pick them up as we go if it's relevant, or perhaps save them till the end if it needs a bit more in-depth discussion. Okay, thank you. Okay. So the patients that I talk about, as previously, are not real individual patients necessarily, but sort of an amalgamation of patients that I've looked after in many years of working in palliative care and in the community. So Pavel, and I think I've got the pronunciation right, having looked after several patients who have that name, non-small cell lung cancer and COPD, a 71-year-old gentleman who's currently having SACT, systemic anti-cancer treatment, which includes chemotherapy and immunotherapy, and is saying that he's got gradually increasing breathlessness. Okay, so just have a think about what our approach to that might be. So, and you've all got slightly different roles: district nursing, GPs, palliative care nurses, or from a social care point of view, you might be going in to see this gentleman at home. If he's gradually more breathless, have a think about what you might do. Could you just launch our next poll, Charlotte, please? So how would you assess him, first of all? And we're assuming that you might not be there in person. Okay, so phone via the DNs, on a video consultation, which we're all slightly better at doing now, face-to-face, or ask palliative care colleagues. Thank you. And I realise those of you who are answering from a GP or GP registrar point of view, you might well try an initial assessment over the phone and then take things from there. But most people are saying that they would like to assess him face to face. Okay. Thank you. And then what are your thoughts might be about what you would do? And I've deliberately not given you very many options, but Charlotte, can you just run the next poll, please? Okay, we're going to consider starting him on morphine, admitting him to hospital or to a hospice, considering antibiotics, or other. And please put your thoughts in the chat, and we'll come to the chat in a minute or so, if that's okay. My chat monitors, Fiona.
All good.
Thank you. Obviously, it's not as easy as 5-option multiple choice questions. Otherwise, we wouldn't need healthcare professionals, would we? We just plug these people into a computer. There's a couple of people considering admission on our poll, and quite a few people there that would like to consider morphine as a treatment. And then perhaps we can see what else we have in terms of comment.
So things coming through the chat, thinking, is there a pattern to his increased breathlessness? For example, when he's anxious, examine him. What are the examination findings when you listen? So clinical assessment, exam first. So there's, yes, combination of both, just a little bit more information needed, and physical exams, the themes coming through so far.
Thank you. Tell me if you want me to carry on, Fiona. Thanks.
I was going to say, don't be shy, folks. Do use the chat. Use the chat if you can. It'll depend on the full history and clinical findings. Yes.
And you've deliberately only got, a few words there, haven't you? Which which you might say isn't realistic, and you would have lots more information if you were in your normal place of work and were plugged into all of the NHS systems. But if we had anybody from the ambulance service on this call, I know that they would tell me that that's more information than they often get.
And Imogen's saying, what would he be like in terms of what would he like in terms of escalation and management? Would he like active investigation, admission, treatment of reversible causes, etc., or focus on symptom management? So that's going a bit in a slightly additional different direction. Reversible causes, positioning, past medical history, oxygen levels, ACP.
Okay.
Okay.
Thank you. I'll carry on then, if that's all right. Thanks, guys, for all your comments and for the interaction. Okay, so management of breathlessness. You've seen this slide before if you've seen the other webinars. Would be really very similar to management of general deterioration, management of pain, management of any other symptom you might think of, in that will be, as lots of you correctly said, you'd be much better in managing this if we were able to identify a cause of the breathlessness. And the way to do that is to take a decent history and to examine him. And that's why it's going to be really difficult to assess him remotely, I think. And we all have to do remote assessment in some circumstances, but you can't remotely listen to his chest. And then you investigate and treat reversible causes appropriately. So that picks up, the comments are what might he want? Would he want to consider other investigations? If you thought it was necessary, would he want to consider admission to hospital, or might he want to be managed in a different way? And then breathlessness, like any other symptom, there are medicines that are maybe of some help in breathlessness, but unlikely to be the mainstay of treatment. Or there's also lots of non-drug measures in breathlessness that might well be useful. The next bit of that slide there is, as any other symptom or any other situation, explain the situation as you see it to your patient if they're able to take part in discussions, or to appropriate others. What do we know about his wishes? Does he have mental capacity in terms of making decisions at the moment? And what can friends, family, or appropriate others tell you about what he might have wanted? Has he made any ACP plans? Acknowledge those previous discussions if he has, but do they apply in this situation? So those of you who've had lots of discussions and teaching and talk about DNA CPR previously, a patient may choose to not have cardiopulmonary resuscitation if they've got a progressive illness. But then if they were to sort of choke over dinner in a restaurant, that might not be a valid situation for which they've made their decision, and you might decide to actually resuscitate them in those circumstances, because it's not the circumstance that you foresaw. And it's always pretty tricky to foresee every single circumstance. But for the common things, like if you got a chest infection, would you want to consider hospital for antibiotics, might be something that we could preempt and have a discussion about. Okay. So assessment. As lots of people correctly said, history and examination. So we said gradually increasing breathlessness for this gentleman, didn't we? Which suggests that, it could be to do with his cancer. It could be to do with something like becoming anemic. It could be some other comorbidity, such as heart failure. It's less likely to be something like a pulmonary embolus if it's gradually increasing breathlessness, because if it was something like that, you would more expect sort of sudden episode of breathlessness, or episodes of breathlessness if it was multiple PEs. So what makes the breathlessness better or worse? Those of you who attempt to run like me badly, breathlessness is typical on exertion. And most breathlessness would be a little bit worse if you exert yourself, and perhaps be relieved by resting and being at rest until it reached a level where you may be breathless at rest. If it has a sort of poor correlation, if you like, to exertion, then it may be that it's associated with things like panic and anxiety, or it may be that there is something more acute happening, like emboli, for example. Okay. Does it change with position? And lots of breathless people are a bit worse if they're lying flat. Yeah, and does it change during the day? What else have people got wrong with them? So we said that our gentleman had lung cancer, but also COPD. You know, with COVID, lots of people who have been more affected by COVID are those with underlying chest conditions who are already a bit breathless. And has he got something that's stopping him from taking big deep breaths in, like a great big liver or lots of fluid on his tummy that's actually stopping him from flattening his diaphragm and taking a proper breath? So in your assessment, so we might do things like this, which again is why you perhaps need to be there in person or have a proxy person doing these things for you if you're giving advice. So you might check oxygen saturations, you might check his pulse. So 94 there on the pulse oximeter. Again, is that good or bad? Well, it depends. If it was somebody who was perfectly fit and well and didn't have any underlying health conditions, then you would expect their oxygen saturations to be a bit higher than that, you know, 97, 98, 99. But for this gentleman, we know that he's got at least 2 lung conditions, including COPD. So it might be that his oxygen saturations are normally at about that level. Lots of COPD patients, we would be aiming for oxygen saturations of sort of 88 to 92, something along those lines. And actually, as I might mention later, if patients are used to their oxygen saturations being a little bit lower, then giving them oxygen and making them higher than they're used to can actually be quite dangerous. Okay. So we need to, somebody who's trained to do so perhaps needs to examine this person and listen to his chest. So that might be where doctors and GPs come in, although lots of our nursing and AHP colleagues now have clinical examination skills, which is great. You're probably going to want to listen to his chest, percuss his chest. Back to medical school, you know, learning to percuss people's chests and seeing whether they've got fluid on their lungs, and listening to your sort of different crackles and wheezes and noises that you hear. Yeah, so examine your patients. Okay. Okay, you can put this in the chat then. What's on the ECG? Didn't realise it was a medical test. Did you? Go on, anybody? Just tell me when we've got an answer, Fiona. I wasn't going to ask everyone.
I'm looking. I'm monitoring.
If not, I might ask you. No, I'm only joking.
No. Who is prepared to put something on the chat?
You can put me back on the spot if you want to. So what's the rhythm like? Is it regular or irregular? Okay. Shall I carry on?
You carry on. I'm just loving this the old-fashioned A4 sheet of ECG, actually, rather than the little ticker tapes as a monitor that we've sometimes seen recently.
So that's quite a fast heart rate for those of you who are used to looking at these things.
Put it out of our misery.
And the rhythm's not very regular, so it's irregularly irregular there. So that's fast AF. And therefore, you know, you have to. People might tell you that they've got palpitations, but you need to take their pulse in order to pick that up and probably listen to their heart as well. So that's my ECG from several years ago. And so just to share my experience, I can tell you that I was fine sitting still with my ECG looking like that. But when I tried to walk across the car park to A&E, I felt quite breathless and not particularly well with it. And then when in A&E, they gave me a defib to hold on my trolley and said, we're going to transfer you to coronary care. That did make me feel quite anxious and panicky. So, you know, if you feel like you can't get your breath, you would automatically perhaps start to panic. And the more you panic, the more you can't get your breath. And people often get into quite a vicious cycle. And those of you who look after patients with COPD, pulmonary fibrosis, heart failure, cancer would be used to patients getting into that sort of cycle. Okay. So that's from this paper this morning. Mark Porter, Media GP. breathlessness and palpitations, it could be AF. So it's just worth bearing in mind because it's really common, and particularly common with lots of our patients and all of the comorbidities that they have. Okay, so identifying causes of breathlessness will help us to be able to manage our patients in the best way. So we said that our gentleman had cancer. He might be breathless because his cancer's worse in his chest. It might be blocking off one of his airways. He could have fluid on his lung. Hemoptysis, coughing up blood. Lymphangitis is cancer spreading into the lymph parts, lymph glands of your chest and the lymphatic vessels. Pulmonary emboli, I've put that under cancer as a cause because lots of people can get PEs, and you're prone to pulmonary emboli if you were to be immobile, you know, have surgery on your leg, for example, or have an injury or go on a long flight. But cancer makes pulmonary emboli and venous thromboembolic disease hugely more common. And we pick up PEs and DVTs all the time in our cancer patients. Okay. So we've talked about big liver and fluid making you breathless. Becoming anemic can make you breathless because the red blood cells carry the oxygen around your body. So if there's less of them to do that, then you have less oxygen in your system and can't breathe so well. And pericardial effusion, so fluid around your heart. And we've talked about fluid, fear and anxiety driving breathlessness and making it seem worse. So I would be really reluctant to put all breathlessness down to panic. I think often the panic is due to the breathlessness and then just feeding it a little bit. So it's, you know, putting breathlessness down to a panic attack in palliative care patients who've got lots of other things. I'd be looking for another cause. Does anybody want to hazard a guess about what might be wrong with this gentleman? Otherwise, I'll have to ask Fiona again. So he's
SBCO is coming.
Yeah.
Bash.
Thank you.
Well done.
So typical appearance of SVCO, which is superior vena caval obstruction, so the main blood vessel that drains blood from the top half of your body, which if you've got a condition such as cancer affecting the sort of central part of your chest, then the tumour can block off that drainage and you can't drain the blood from the top half of your body as well as you might, which gives you a sort of swollen face, swollen arms, prominent blood vessels over your chest where the blood's trying to find another way around. It can make people very breathless, obviously, can give them headaches and make them confused. You need to be able to recognise that and then consider whether any treatment's appropriate, because these patients can sometimes have a stent put in to open up their SVC and drain the blood, or can sometimes have radiotherapy or to go on steroid tablets, which might help. You know, on the other hand, it might be that they're very poorly and towards the end of their life, either wouldn't want all of those things or it wouldn't be appropriate, and you'd be better to manage them symptomatically with medicines like morphine for breathlessness and maybe some benzodiazepines for panicky episodes. Okay. Other causes, so to do with treatment, cancer treatments can make people breathless because they make you prone to infection, or post-radiotherapy, you might get some swelling around your chest, which would make you breathless. Some medicines can make you breathless because they make you regain fluid or make you wheezy. You might have arrhythmias, as we've said, COPD and heart failure, or another important cause is that if you become deconditioned, so if patients spend lots of time sitting because they're not very mobile, they then get, you know, less used to making any exertion at all. And so even walking around their house can make them quite breathless and decondition their muscles. And breathlessness is common when people are dying. I think up to 70% of cancer patients would be breathless, perhaps towards the end of their life. Lots of other causes there. Okay. So investigate and treat reversible causes if appropriate, and consider basic tests like a chest x-ray or a full blood count perhaps, and then other things if appropriate and if it fits in with what you might suspect. So peak flow if they're wheezy perhaps, or got COPD, you may, you know, if they look like they've got cardiac failure, you may think about things like echocardiograms. CTPA is the sort of modern test that we would use to look for PEs. Okay. That's a chest x-ray of lymphangitis, so nasty cancer in the lymphatic vessels in your chest, which makes you very breathless. And a CT-PA there showing pulmonary emboli. It might not be appropriate to treat, as we said. Antibiotics in someone who's dying might not be the right thing to do. It depends on what they want. It depends on what you think as a clinician. And breathlessness really common as people are dying. Okay. We've talked a lot about the sort of fear of dying, anxiety, breathlessness cycle there, one driving the other. So it's really important to ask people how they're feeling and what they fear, what things are in their head. Lots of people will say, I fear not being able to get my next breath. I fear that I'm going to suffocate or I'm going to choke. And, you can reassure them in that. People don't choke and they don't suffocate. And if they're very breathless, we can at least alleviate their symptoms to a point, or at least improve them with medicines and non-drug measures. Okay. And realistic goals would be perhaps pacing and not exerting yourself too much, or maybe putting in appropriate other measures like some equipment or perhaps a stair lift. So company and reassurance can be helpful. Simple handheld fan, so the air blowing across your face, can be a big help in breathlessness. Breathing exercises, so relaxation and breathing out slowly and not sort of panicky, and breathe in and in and in and in and in, and then not have your lungs really expanded and not able to get the air out. Being in the correct position can help for breathing. Complementary therapies, reflexology, relaxation, aromatherapy, that sort of stuff. Hypnotherapy is something that before COVID we found useful in the hospice for breathless patients. And modifying some of your lifestyle can be useful. So I'll just go quickly over drug management then. Morphine is probably the best evidence for morphine and related opioids in terms of breathlessness. I don't know exactly how they work. It's all to do with work of breathing. Don't worry, but there is a good evidence that they are helpful for breathlessness. Usually lower doses than we might use for pain. And even in non-cancer breathlessness, in conditions like COPD, many years ago when I trained, we were sort of taught to avoid opioids for COPD patients because it could give them respiratory depression. But we've found since then that using small doses, titrating carefully and monitoring our patients, those sort of medicines can be really helpful. So benzodiazepines, again, I'm not sure that they work specifically for breathlessness in themselves, but if they work for the panic and anxiety part of it that might be driving breathlessness, then things like lorazepam and diazepam could be really helpful. Or for people with a slightly longer prognosis, if they're very, very anxious, SSRIs, so medicines like citalopram and other antidepressants may well be useful. If people are wheezy or they've got COPD, or they've got lots of thick secretions, things like saline nebulizers might be helpful, or salbutamol for wheeze. Steroids could be helpful for COPD patients who are wheezy, or for cancer patients who've perhaps got a big tumour that's obstructing one of the airways. Oxygen's probably not helpful in itself for breathlessness, and might be helpful if people are actually hypoxic, but I would try simpler measures such as a fan first, especially in the community, and also to remember that too much oxygen can also be harmful depending on your patient's condition. And attending to everything else like pain, bowels, mouth care, pressure areas is all part of holistic care of breathlessness. So back to our patient, Pavel. So chest x-ray showed something that looked like that for those of you who are used to looking at chest x-rays, and for those of you who are not, the sort of big white bit that's on his right and our left is not supposed to be there and is typical of fluid, sort of pleural effusion. And cancer patients can commonly get that where the fluid's in the wrong place. It's in the lining between the lungs and the chest. And so there's probably a good few litres in there. And as it builds up, it can squash your lung. So he's already got COPD and cancer. And then if his right lung is partly squished there, then that could make him more breathless. So what's the treatment for that? Well, you can put a tube in just through the ribs and drain some of that fluid out, which is good relief from breathlessness for patients like him. And what we can sometimes do is put in indwelling drains. Those of you who are district nurses or your GPs have probably seen these in the community, where either our district nursing colleagues or patients actually can learn to drain a bit of fluid themselves, because it tends to come back. So that is him. And I think I'm going to leave it there, if that's okay. So happy to answer any questions quickly if you've got any burning questions, or if not, happy to hand over to Clea, my colleague. I'm going to stop sharing for a minute, if that's okay. So Fiona, if there's nothing desperate in the chat, I thought I'd hand over to Clea for the next bit of our talk, if that's all right.
I think so, yes. Nothing additional at the moment. So keep going.
Okay.
Okay, thank you, Jo. Can you hear me okay?
Yes.
Yes, okay. So I'm Clea Atkinson. I'm one of the palliative care consultants. I work primarily in the Heath, but I do cover UHL as well. And as Jo mentioned, I'm a palliative care consultant, but I also lead a supportive care team trying to support patients with advanced heart failure as well. So I'm going to talk a little bit about the service that we set up here in Cardiff and Vale, which we began about 6 years ago to start with. I'll just, next slide, please. So what I hope to cover, yes, the patient experience of advanced heart failure in the last years of life and what these patients actually want from healthcare. I'm going to try and outline the evidence for palliative care input and describe the supportive care service approach that we've developed, and then talk about outcomes of this new approach before hopefully having time to cover some of the common symptoms in advanced heart failure and how they're managed. Next slide. So what we know about the patients with advancing heart failure is that they have as high a symptom burden as patients with metastatic cancer. So associated with this is a very poor quality of life, and these patients are often creating a lot of demand on the people around them who take care of them and who love them. They also are the classic revolving door patients who are coming in and out of hospital with complications of their heart failure quite often. And with that is this notoriously uncertain illness trajectory that causes so much fear and uncertainty. And yet only about 6% of these patients are ever referred to palliative care for a variety of reasons. Probably the main one being that people don't really know when to refer, but there are a lot of other barriers to referral as well, which we've tried to overcome with this new approach to their care in Cardiff and Vale. And hugely expensive to the NHS, because patients are coming in for addressing these healthcare needs that are presenting at the front door, and yet often these patients are just being plugged into a system and having interventions and investigations and interventions that they don't really need. Okay, next slide. So if we look at the trajectory of the heart failure patient, it's much more bumpy than patients with cancer as a generalization. And as patients tend towards the later phases of their lives, they will be in and out of hospital, as I've described. On the first episode of admission to hospital, a heart failure patient has about a 10% chance of dying, and it's something similar each time they come into hospital. So it's extremely frightening for them. And despite all these huge advances in the management of heart failure, which are ever improving the outcomes and survival of heart failure patients, we still weren't really getting the last phase of these patients' lives, the last 1 to 2 years, quite right. So next slide. So if you look at the literature and you actually ask patients what they actually want, chronic disease patients actually would like better pain and symptom control. So we're doing so much better in the management of cancer patients, but forgetting then this other group, the non-cancer patients, who are equally as needy. And these patients want a better sense of control. This uncertain trajectory that's so frightening. They want to feel more that they're back in the driving seat. They also don't want to be causing this huge burden on the people around them that they care about and who they love. And instead, they'd like to be strengthening those relationships with their loved ones. And they will often say that they don't want to have prolongation of their dying phase inappropriately once they understand that they have a life-limiting condition that's actually going to lead to their death. Next slide. And if we look at the Voices study, about 81% of the general population, granted that's asking people who aren't actually facing the end of their life, but if you ask the general population, about 81% of people overall would actually choose to die at home. And if you look at advanced heart failure patients, it's about the same number that actually die in hospital. So we realised that we were getting something a bit wrong, and that we perhaps had to have a real rethink about how we were addressing the needs of these patients. So that's why we started from scratch to create something different to address the needs of this patient group. So the evidence for palliative care input is ever increasing. As I've said, there's about only 6% of these patients ever referred to palliative care. And yet we know in the last decade or so that mounting evidence has been showing that if you provide patients with palliative care input in any shape or form, whether that's in clinics, co-specialty clinics, or in the community palliative care teams, or general palliative care, that it will improve symptom control and improve their quality of life and well-being, which is what they want. And indeed, these patients can actually improve their functional level and become more self-efficacious, going back up the NYHA classification for functional ability. So patients can regain some sense of control in their activities of daily living. And palliative care input can help with advanced care planning, as Jo has mentioned previously, and lower readmission rates. Next slide. But what we noticed when we started to help with the care of these patients was that there were certain things that were underlying the difficulty in surmounting the referral barriers. And one of the main things was that these patients have a really strong trust in their cardiology and heart failure teams. Probably because they've had their life saved on a number of occasions, maybe come in with an MI or some other acute presentation related to their heart, and been saved, and often had their prognosis extended with a variety of different heroic strategies, especially when coming in out of hospital, very, very frightened, perhaps with chest pain or breathlessness and thinking that they might die. All those things tend to really build the trust that they have in the heart failure team. And there's a limited acceptance of the life-limiting nature of their illness. These patients don't tend to really understand that they're actually in the last years of their life, probably because that's not often explicitly explained. I think cardiologists will generally be in that specialty because they want to try and save life, and that's a really good thing, but it does mean that the patients tend to have not really had conversations around whether their condition might actually ultimately lead to their death. And as I've said, this focus on extended survival, very, very important if you go into hospital with an MI, but not quite so useful when you're actually getting into the chronic disease phase of heart failure. And this dependency on acute services that is just reinforced again and again by these repeated admissions and very, very frightening episodes that they are, just reinforces this cycle of fear and sort of clinging on to the cardiology and heart failure teams. And when they come in, they tend to have avoidable investigation and intervention. And what we've noticed is that the more we get involved in these patients' care, they are frequently asking us, please, can I not go back into the hospital? Because they just have a really poor experience. They're away from their loved ones. They're in a hospital. Maybe they get hospital-acquired infections. Maybe they've come through, well, often they've come through A&E, which these days looks a bit like Beirut. So, you know, they have a horrible experience of hospital, and many of them dying in hospital on cardiology wards, and these days often with very few visitors, which is awful. So we set up this new service, and a number of the elements of this service aren't particularly new in many regards, particularly to palliative care. We're used to working hand in hand with our oncology colleagues, but I'd say it's a bit like a cake. You've got some ingredients just refashioned in a particular way, and the way you bake your cake makes all the difference to the kind of cake you've got. So we've got the central multidisciplinary team meetings, which are highly co-speciality. In those meetings, we discuss all the new referrals. We talk about whether they're appropriately optimized, whether there's anything else that they should have done before they start to come down the supportive care track with us. It's understood that this is an additional layer of support. It is not instead of cardiology. So you get over the barrier of cardiology having to release the patients to us, when often there are other things that might help in their ongoing supportive and palliative phase. So it's very much overlapping. And we jointly discuss the management of not just the new patients, but all of the patients who are seeing in clinic, or ones who are having problems when we're going out and seeing them in community. As these patients get progressively less well, we will see them more and more in community, but we will continue to feed back to cardiology and heart failure teams to make sure that we're still taking any expertise that might help the patients out to community. I think that's really important as well, because as heart failure management has become ever more complicated and continues to be, with more and more new drugs coming online, synchronized pacing, etc., the divide grows and grows between secondary and primary care. So by keeping it a highly co-speciality, we can take the care back out to the community and support primary care as these patients inch towards the end of their life. So we do have some criteria, but very much it's about expert opinion as to whether or not these patients may be in the last 1 to 2 years of their lives. We also run co-speciality clinics. Sorry, just to mention co-speciality clinics, either in parallel. We're either running them right next door to the cardiology team, or we have even been running clinics where we're there together, seeing the patients together. There's massive focus on trying to turn it around so that we put the patients back in control of what's happening to them. So we make the clinics very flexible, responsive to the patients who are having problems, rather than having routine, set, regular appointments. So sort of flipping it around and trying to make, if a patient struggles to come up to clinic, not 2 appointments to come up to see cardiology and us, instead see us at the same time. So we're always thinking about the best way for the patient. If they can't come up to the clinic because it takes them ages to get ready in the morning, and patients were saying, oh, I have to get up at 4 a.m. to be ready, we listen and we make the appointments later. If people don't make it to the clinic, we don't just say, oh, DNA, 1 stroke and you're out. We ring them and we say, what's happened? Are you okay? Is there a reason why? Okay, next slide. So to look at whether or not we were being effective, it's quite difficult to set up a new form of service to actually evaluate whether it's of benefit, because once you've put that service into place, how do you evaluate it? So we decided that what we would do is take each individual patient and compare them to themselves. So sort of like an n=1 essentially, and then amalgamate all of those patients as we were seeing more and more people, and put that data together to give us an idea as to whether or not we were improving things. We knew we wanted to reduce the amount of time that these patients were in hospital, and if possible, reduce the amount of hospital deaths. We were recognising that from the point of referral, we were seeing them in clinic very much, if we could, very much trying to build on good rapport, symptom control, which we knew was very important, as much as possible, asking them to bring their loved ones into the clinic and seeing them together. Gradual advanced care planning, because it is important, but really focusing on the rapport so that we could help them as they're going along their trajectory, to make the process of advanced care planning less painful all round, because when people understand what's happening, we find those decisions much more easily. We do use subcutaneous diuretic infusions when we recognise that patients have been coming back into hospital for intravenous diuretics that has been essentially for palliation in patients who are fully optimised in every other way. And also trying to help these patients to gain access to the hospice, because we recognise that sometimes these patients aren't getting a bite of that cherry, and hospice in their turn wanting to have more non-cancer patients ongoing now into the future. So we compared the 1 year prior to referral with the point of referral up to death or to the end of the study period, and then we indexed the data to see if we were having an impact. Next slide. And what we found is that after initial bumps in 2016 and 2017, where if you look at all cause, which is the all cause of admissions, which is the purple bars, we didn't really seem to be making a huge impact. Remembering, however, that these patients are deteriorating patients, so you would expect them to be having episodes progressively of increased illness and becoming less and less well functionally, and potentially coming into hospital more. So the purple bars in 2016 and 2017 would show that. But when we look progressively over the 5-year period that we evaluated, we've progressively been improving on that, and both all cause admissions and heart failure related admissions improve after referral to supportive care service. And in actual fact, we've hit statistical significance when we've used statistical testing in 2019, 2020, and when we look at the whole cohort of over 300 patients. Next slide. But most importantly of all is whether or not the patients actually like what we're providing to them. And we found, when we evaluated in the middle of the 5-year period and also at the end of 2020, that patients, a high proportion of patients up in the mid-80s or even nudging into the 90s would recommend this service to somebody else in the same position. And a high proportion feel that the care that's being offered is compassionate, that they feel listened to and can talk about their thoughts and feelings, which often when they're coming in and out of acute setting, they're not having opportunity to talk much at all. So we wanted to be trying to improve their symptoms. These are often some of the most symptomatic and difficult symptoms that these patients experience, with breathlessness, fatigue, etc. But large proportions of these patients feel that in some cases there was resolution of symptoms, but certainly that there was better control. And we'll talk a bit more about symptom control shortly. and overall that we're improving quality of life, which is what we had hoped to do, and that they felt the benefit of this joint speciality approach, particularly in terms of coordinating their care better. Next slide. And in terms of place of death, which was something we knew patients wanted and we were hoping to achieve, if you look at 2016 to 2019, we've halved the expected rate of death in hospital and significantly increased the number of deaths at home. Unfortunately, that didn't hold out in 2020 because of the impact of COVID. Despite the fact that we were still keeping people out of hospital, still large numbers did die in hospital, regrettably. But that was probably because a lot of the time COVID was influencing patients. If they became more breathless, they were frightened and they were bouncing straight into hospital. But if you look at the whole of the 5-year period, it is borne out that we have halved the rate of in-hospital death. Next slide. So I'm just going to pause there just to ask if anybody wanted to ask any questions about the supportive care service at all. I can't see the chat, so I don't know.
That's okay, Claire. I'm looking at the chat. Nothing's come through as yet. It's 13:52, so it may be just if you've primed people, if people want to pop questions in the chat, and we can come back to it a little bit later on, perhaps.
Okay, lovely. So I'm just going to talk about the most important things to know about symptom control in heart failure. So number one is that they are having such a roller coaster experience and many different types of symptoms. So multiple overlapping symptoms. These patients are often depressed and fatigued and breathless and have pain. And as I've said, often the symptoms are amongst the most difficult to control. As Joe's been describing, breathlessness is extremely difficult, although we do have some things to try and help improve the coping with that. But also in heart failure, you've got this fluctuating severity of symptoms. So you've got moving targets. So breathlessness will often change, pain will often change, constipation will often be changing. And the patients often have lots of psychological overlay, with fear, anxiety, and depression being really, really prominent. And there are many symptom control prescribing limitations, particularly around things like antiemetics and with use of pain relief. And not forgetting that these patients often have fluctuating levels of renal impairment, and not just a little bit of renal impairment, often significant renal impairment that's coming, that's fluctuating as we're using diuretics to try and help with the fluid control. So what's the best approach for these patients? Well, I would say that the approach I take is a bit different to cancer patients. I tend to go for small symptom improvements, looking to have those improvements added together to overall give a better benefit to patients' quality of life. So I don't tend to, with cancer patients, I would try to treat every single symptom 100%. I tend to be a bit more inching forward with these patients because you're trying to get their trust, you're trying to improve their quality of life inch-wise. So and you've got a bit more time because you've got to have these patients for a little bit longer, perhaps, than the palliative patients. So as I've said, aiming for a stepwise symptom improvement, really focusing on fear management, building good rapport, supporting patients, talking to them, listening, helping them understand what's happening to them, trying to return the sense of control to the patients. And the heart failure nurses report, having not trusted us very much right at the beginning because they care about their patients a great deal, that they see that the patients come to understand and accept that they have a life-limiting condition, and it returns the sense of control and empowerment to the patients. And then we help them to engage with our service the best way for them rather than the other way around. So just a little bit about fluid overload. It's important to understand that there are a number of reasons why fluid overload in advanced heart failure can come out of control. Poor compliance is really, really high up on the list. Infections, chest infections, really common when people have just got a tendency towards fluid overload, but UTI can do it too. Any infection, cellulitis can do it. Arrhythmia, Joe's mentioned, atrial fibrillation, ventricular arrhythmias are also common in these patients. Hopefully they've got an ICD, and if they've got a tendency that way. But AF is something that can be simply treated in reverse, so we must be sure to spot that. You also see heart block, you know, and these are things we can pick up with simple feeling of the pulse. They're all at risk, high risk of acute coronary syndromes. We need to be talking to patients so that we aren't necessarily rushing an end-stage heart failure patient into hospital who might be having some myocardial ischemia. That may not be what they want. We might manage them instead with some morphine at home. The worsening renal function can lead to difficulties in fluid, the body coping with fluid. PEs are really common. These patients tend to run dehydrated and be immobile, and not forgetting that a lot of these patients have pacemakers in situ, and if there's dysfunction in the pacemaker, that can sometimes throw them into fluid overload. So ensuring that they've got compliance, excluding infection, checking the pulse to see if there's an arrhythmia, looking at the diuretics, simple changes in those can sometimes be enough to just improve things without hospital admission. We do use subcut furosemide infusion, as a lot of you will by now have probably come across. It does work well, it's gentle, we're using it as a palliation. Does take a 24 hours, 48 hours to kick in, slower than IV infusion that you might have come across when working in hospitals in the past. We do use strong thiazides sometimes in low doses, like metolazone, work really well with loop diuretics to kick the kidneys into diuresis, and as Joe's mentioned, low dose oxycodone, getting a pacemaker check. So I think I'm probably running out of time, and that's probably the most. The slides will be available to everybody. I've done some nice little cartoons as well. You're very welcome to email me if you wanted to ask me anything about the specific symptom control. But I think the fluid overload is probably the most important one. Just remembering that patients get fluid in their abdomens, get build up ascites, and paracentesis can often be very helpful. So those are probably the things I mostly think about when I'm trying to manage the fluid overload in advanced heart failure patients, to avoid them having to come in extremis. Is that okay? I'm not going to try and rattle through the rest because there's lots of them, and I think it'll be too much to try and squeeze in very quickly. So in summary, yeah, they're good pictures. In summary, we're trying to re-empower the patients, go for a co-speciality outreach approach, really tailor and be flexible to the patients, adapt our symptom control. Lots of the antiemetics, for example, prolonged QT. Well, we still need to use antiemetics. These patients will often have gastric holdup from ascites and a congested liver. So low dose metoclopramide is often what I would choose. And just trying to reconnect secondary and primary care when the care in secondary care has become so specialised, with the aim of avoiding unnecessary readmissions, which patients just don't want. And if you do that, if you can avoid readmission, if you can avoid admissions in the 6 months prior to death, you've got a much better chance of helping patients to die at home when that's what they want.
Fantastic. Clear. Thank you. We've got the evaluation code there, but do please, folks, do if you've got any questions at all while we are lucky enough to have Clear with us.
Can I ask a quick question, Clear?
Yes, Emily, please do.
It might be helpful, Clear, if you could just explain, as us for people working in the community who've got patients on maximal tolerated therapy who think may benefit from the service, how we refer into yourselves.
Okay, so we do have a dedicated email, which perhaps Sean, could you pop that in the chat if you're still on the chat, or Imogen? and you can just email us directly. We will then take those referrals to our co-speciality MDT and discuss them there. So some of you may have experience of that sometimes heart failure, that the heart failure team, Professor Yusuf, may wish to do a couple of other things before he then passes them back to us. Or if it's a heart failure patient who is known to the heart failure service, you can ask the heart failure nurses to consider referral to us, and they will bring them to the MDT as well. So either of those ways is fine. And I think
Lovely,
Sean's
thank
just
you.
put that in the chat there.
And thank you, Claire, because I think you've answered Megan's question, which is just who can GPs contact for advice? So they could contact heart failure nurses directly, from what you're saying.
They can, or directly to us. If you know, and you know, I'm sure lots of the GPs know that I'm more than happy to be contacted directly if there's specific queries.
Brilliant, thank you. I'm fascinated by the figures are fantastic, and just the big impact that probably COVID had on the figures for 2020 and presumably 2021, and just a mindfulness really, just that interpreting data for that time is going to be complicated.
Yeah, absolutely. I mean, it was nice to see that we were still keeping people out of hospital, and yet the hospital deaths for this group flicked back up to 80. It's interesting, isn't it?
Yes,
So I
yes.
think we were keeping people out of hospital, but then, you know, when they were becoming very breathless, which was often the cause for admission, they were just going straight into hospital. I mean, that was probably because of the pressures on GP services as well, I would imagine.
I think the other interesting thing is just the different approach, the slightly different approach for somebody with cancer compared with somebody with heart failure, and just that, you know, that little things, concentrating on little things might make a huge difference, whereas rather than the sort of the comprehensive, the other way around. I think that's in your, that sounds as if that's been a real kind of practice changing reflection.
Yeah,
observation.
absolutely. Yeah. I've just really changed the way I apply what I do to these, and get their confidence. They have to get to know us and trust us, and vice versa. Well, obviously we trust our patients, but you know, we have to get their confidence so that we can turn around the way that we're delivering this care, so that when push comes to shove, they get in touch with us in a timely fashion, so that if there are things that we can reverse and do something about, then we've got time to do it. Whereas these patients who've become so afraid of going back into hospital would often hold off, and then they're in extremis and they have no choice. So it's, you know, helping them understand what's happening, and give them that support so that they, you know, they trust us when the chips are down, is basically.
Absolutely. No, great. And thank you, Imogen. You've also said that you're getting referrals that may be suitable passed on to you from community palliative care teams as well. So
yeah, I just wanted to pick up on that, Fiona. Yeah, we work quite closely with the heart failure team, and we often get a referral, and we'll chat to the team as well, and we feel if they feel it's more appropriate for their service, they'll pick them up and refer back to us if need be.
fantastic.
And I think that's a great fail safe, you know, that, and for GPs, you know, that if you're not sure, it's okay to refer them, and we'll discuss them in the MDT and make sure. And that's so important, because when we see the patients, we need to know that we're talking from a place of confidence that this patient is going the right direction to be coming down supportive care, which is obviously going to then lead into palliative care.
I'm going to make a suggestion. I think I know some people have gone already. I think thank you so much, both to Jo and to Claire, for this webinar, and really raising all the intricacies around managing breathlessness, but giving a framework for us to do so. The more details are in the chat, but I'm going to suggest that Charlotte, we can stop